I was going to present the consensus statement from a meeting we had last year. It was sponsored by the Chiari-Sringamalia Foundation. And we met in San Francisco right before the American Association of Neurological Surgery. There are about 20 universities represented, and we heard lectures from people all over the world, some of the most prominent professors such as Peter Rowe and Rodney Graham from London, and a number of neurosurgeons from Japan, China, Europe, and around the United States. And we at the end of the day, we looked at certain statements and agreed on them or didn't. And so I'd like to present very briefly a few things that we agreed upon in the consensus statement. And the first was that it's reasonable to assert that ventral brainstem compression or deformity is deleterious. And then which seems obvious to all of us, and then we agreed that there were certain tools that we might use to predict this deformative stress. And the first was a clinical assessment, which we called, or which we said was manifest in the cervical medullary syndrome. And the cervical medullary syndrome are all those symptoms that arise when you deform and compress the brainstem and upper spinal cord, including headache, suboccipital or neck pain, double vision, decreased or blurry vision, dizziness, vertigo, imbalance, tinnitus, decreased hearing, altered hearing. Some of the dysautonomic findings, some of the postural orthostatic tachycardia, syncope or presyncope, dysarthria, dysphagia, choking, altered breathing, altered sleep architecture, weakness, clumsiness, spasticity, altered sensation, paresthesias, dysesthesias, gait changes, urinary urgency or frequency. These are commonly found symptoms with brainstem compression. That is the cervical medullary syndrome. And then we agreed that there were three angles that are well supported in the literature, and that it is not that it would be useful for any neurosurgeon to use these. And they are the clivoaxial angle, the Grab-Mapstone-Oakes measurement, and the Harris measurement. And Dr. Kobe went over these, and just to sort of burn it into your memory banks, I'm going to recapitulate what he said. Here's the normal clivoaxial angle in neutral. And did we have a pointer? Yes. So is the clivus, the back of the axis. That's a normal clivoaxial angle, 165 degrees. On flexion, it decreases 10% to 155 degrees. And on extension, it increases to 175 degrees. That's normal. Now, Doug Brockmeyer, Robert Bolo found that of looking back at 100 patients with Chiari malformation, they found that patients with the clival cervical angle, which is also essentially the clivoaxial angle, if that angle was less than 125 degrees, they felt that those patients were at risk for needing fusion stabilization. And Kim, Riekade, Klopferstein, Sontag in 2004 published on a series of 10 patients, and I mentioned this yesterday, I'll just say it again, that of a group of Chiari patients who had undergone standard decompression, 10 had failed, and when they looked at these 10, they found an abnormal clivoaxial angle, and they went back in and performed an open traction reduction and a fusion stabilization, and 9 of those 10 patients substantially improved. And that was published in Neurosurgery in 2004. And apropos of one of the films that Dr. Kobe showed, where there was a residual syringomyelia following decompression of the syrinx. Kubota in Japan reported on a large series of patients with Chiari malformations and syringomyelia, and if the clivoaxial angle was less than 130 degrees, the syrinx did not resolve. So there are a number of reports in the literature that if the clivoaxial angle is abnormally acute, then you get deformation of the brainstem and continued symptoms. This clivoaxial angle really looks, if you look at it, any radiologist or neurosurgeon would say that's normal, but if you measure the angle, it's abnormal. So we agreed that it's reasonable for the neurosurgeon or radiologist to measure the clivoaxial angle when evaluating a patient for cervical medullary syndrome. The second metric is ventral brainstem compression. And this is the angle between, this is a measurement that's taken by drawing a line from the basion to the posterior inferior portion of C2, and then measuring the perpendicular distance from that line to the dura. So you need to do this on an MRI. And if that measurement is 9 millimeters or more, then they're at risk for ventral brainstem compression. An important caveat is that the T2-weighted MRI shows a flare and may not show the ventral brainstem compression, because any spinal fluid there can, by virtue of the flare, give the impression that there's no ventral brainstem compression. But if you go back and look at the CT scan, then it's quite a different perspective. So this is the Grab-Oaks methodology. And we have, in the consensus statement, we also agreed that some neurosurgeons might use 8 millimeters as the pathological threshold. So the consensus statement read that in the setting of cervical medullary syndrome, it's reasonable to measure the Grab-Oaks line or the basion perpendicular C2 line to determine whether there's a ventral brainstem compression. The third measurement we agreed upon was the Harris measurement. And Harris measured 400 normal subjects and found that the distance from the basion to the top of the odontoid was never more than 12 millimeters. If it was more than 12 millimeters, then that represented instability. And he also he did a measurement horizontally and also vertically. And the horizontal measurement should never be more than 12 millimeters, and the vertical measurement should never be more than 12 millimeters. So this is the measurement from the basion to the posterior axial line. Now, the good thing about this measurement is that it allows us to measure translation. Using dynamic MRIs, we can sometimes see the skull sliding forward on the spine in flexion and sliding backwards in extension. And that should never happen. The skull should pivot over one point on top of the odontoid, so that Fielding said flexion extension is the only motion at the normal occipito-atlantal joint. Verne said there's no horizontal translation. Wiesel and Rothman said the normal horizontal translation in flexion extension is no more than 1 millimeter. And White and Punjabi said that more than 1 millimeter of translation in flexion extension is an important and useful criterion. Symptoms of weakness of the limbs and occipital pain are additional indications of instability. So you're allowed 1 millimeter of movement of the base of the skull, but very often we we see a lot more movement. Well, here's an extension. The line seems to have dropped out, but you can see that the basion lies right over the middle of the odontoid, and on flexion, it's moved forward. So that represented a sliding forward of about 6 millimeters. So in our consensus statement, we said in the presence of known ligamentous instability, i.e. hereditary hypermobility connective tissue disorder, the basion axis, the basion to posterior axial line is a useful measurement for measuring translation. Now, there are a few other potential measurements that one could use. Holy and Brewer looked at 600 normal cervical spine x-rays, and they found that the middle of the odontoid should lie directly beneath the basion right there, and within 5 millimeters. And they said if it was more than 10 millimeters on plain x-ray, it was abnormal. So you might use 10 millimeters as your pathological threshold. And this is the measurement I'm talking about right here, the basion to the top of the odontoid. So we should ask ourselves if it's reasonable then to use that measurement to assess instability. Bull, Nixon, and Pratt reported on the palato-atlantal angle, which is the angle between the hard palate, the roof of the mouth, which is right here, and the top of the C1 ring right here. And that angle here, the palato-atlantal angle, if that's more than 13 degrees, that's considered unstable. And Lee used what's called Lee's X lines, and there's one line that goes from the basion to the mid lamina of C2, and another line that goes from here, the opistheon, down to the posterior aspect of C2. And this is the line of interest. The odontoid should not transgress that line. If it does, if the odontoid transgresses the Lee's X line, then that represents basal invagination. And Lee's X line, in many respects, is like a Wackenheim's line, which is simply the line drawn along the back of the sphenoid bone, of the clivus. So the cervical medullary syndrome is the manifestation of brainstem and upper spinal cord deformation, and radiological metrics may be used to measure potentially significant deformation of the neuraxis. The clivoaxial angle, Grab-Oak's measurement, and the Harris measurement. But I agree completely with Dr. Kobe that we often find very abnormal radiological measurements. If they don't have the cervical medullary syndrome and the other findings to go along with it, then we don't operate on the basis of the x-rays. We merely use the x-rays to confirm our clinical diagnoses. And so it's important to put the whole picture together. When people ask me to review their films, I explain that it's really meaningless to read someone's MRIs without examining them and getting the full history. So thank you for your attention.